So we're going to tackle there are many issues to look at here in this election, but one of the things that clearly is, as the New York Times pointed out this morning, is affecting a number of congressional elections across the country is this question of Medicare. There were clearly partisan battles over Medicare. President Barack Obama had his plan. It was built around his Health Care Act, the ACA. There was some people accusing him of taking $700 million out. He's saying, no, we're taking it out to put it back in. And other people are saying, and so the argument is Medicare solvent? Is it insolvent? Are the costs too high? Why are the costs too high? Does anybody's program really answer the question? Or are we all playing politics with this word? And many people, especially younger people who are see themselves aging at some point, are worried, will Medicare be there for them? There are people who are in Medicare now, and people are saying, well, if there are too many of you and it's your fault the prices are up. Is that the case? So we'll talk about all that and more in the course of this hour. We are joined here in studio by Dr. Bradley Herring, who is Associate Professor of Health Policy and Management and Director of the PhD Program in Health Economics and Policy at the Johns Hopkins Bloomberg School of Public Health. And good to see you again, Bradley. Welcome to the studio.
Thanks a lot. Good to be back.
Lovely to have you. Joe Antos is with us. Joe Antos is the William H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute in Washington, D.C. And Joe, welcome. Good to have you with us as well.
Great to be here.
And Brenda Sulick is with us. Is it Sulick or Sulick?
Sulick.
Good. I'm glad I got it right. Brenda Sulick is with us. She's Senior Policy Analyst with the National Committee to Preserve Social Security and Medicare. And Brenda, welcome. Good to have you with us as well.
Thank you.
And I want you all to join us here at 410-319-8888. Write to us here at steinershow@gmail.com with your thoughts. Jump on Facebook, which I'm going to open up right now to see if any of you have written in to either one of our Facebook pages, and we will look at your thoughts there and bring your thoughts to the airwaves. 410-319-8888. So we talked, Bradley, just briefly before we began the show, that this is one of these issues that this stays with us for forever. And I think that there's a lot of confusion and a lot of fear around this issue.
Sure.
So where do we even begin? I mean, there are many ways we look at this. There's the President Barack Obama's plan that came with ACA, which we can go over. There's what Mitt Romney says is his plan, and this is not a partisan comment I'm about to make, but it seems to kind of waver in the wind and shift every few weeks. Now it's changing again with his new vice presidential nominee, and then there's also Ryan's plan. So how do we parse our way through this?
Well, so interestingly, there's actually even 4 potential Ryan plans. He's come out with a couple of different proposals that are bipartisan, with Alice Rivlin first, and then Ron Wyden from Oregon, and has had a couple of proposals for the 2012 Republican budget and then the 2013 Republican budget. The thing that's kind of common across all of the Ryan proposals is this notion of premium support. So what is premium support? Well, the Medicare program now is essentially a defined benefit, right? So if you're a senior citizen, you're over 65, and you want to receive health care, you go to the hospital, you go to the physician, and the Medicare program pays the bill for you. I mean, maybe you pay a co-payment of 25% for a physician visit, or pay the deductible for the hospitalization, but it's essentially a defined benefit for people. A premium support model would essentially take that money that's paid for the health care for seniors and essentially provide it as a lump sum amount to seniors to in turn, quote unquote, support the premium they would pay towards a private health insurance plan. And essentially give seniors the option of choosing across different private plans, or perhaps in the latest iteration of the Ryan proposal, stay in the current Medicare plan if they so choose. So in some sense, that's kind of simple, right? But the devil is in the details, largely in terms of just how much money do seniors get, and how fast does that money grow over time,
or dissipate.
Or dissipate. Yeah, exactly. So if you're thinking about saving money, you just essentially kind of grow that money at a slower rate than the cost of healthcare has grown historically.
So Brenda Sulick, it seems to me that's one of the things that organizations like yours seem to kind of have concern with, because it's, as from your perspective, kind of tantamount to privatizing Medicare.
Our organization is very much opposed to the Ryan voucher plan. We think of Medicare as one of the most successful programs in the country. It's been around for 47 years. And I think we need to think about why Medicare was put into place. Before Medicare, in 1965, we had millions of people, 35%, living in poverty, and 50% of seniors did not have any insurance. So when I think about the differences between the plans, the traditional plan, what people pay into now, for the most part, is a guaranteed benefit, which means that there is a guarantee that they will get their services. When you talk about the Ryan plan, we view it as ending traditional Medicare as we know it, privatizing it, leaving seniors on their own to deal with private insurers, and it may be harder for them to choose doctors. And something that's very important is the Ryan plan also repeals the Affordable Care Act, and that means we go back to people worrying about pre-existing conditions and having to pay more for the prescription drugs.
And so let's turn to Joe Antos. Excuse me, I didn't mean to change your name, Joe Antos. and again, I've been reading some of the things you've been writing. And your perspective would be that Ryan plan that we're describing is something that would be a positive step for Medicare.
Positive and a necessary step. The problem that we have, and this is not just a Medicare problem, this is a problem throughout the health sector, is the health sector is renowned for inefficiency and waste. Medicare is the largest payer in this country. Medicare dominates the health sector. Medicare's structural inefficiencies adversely affect not just the cost and quality of health care for Medicare beneficiaries, they adversely affect the cost and quality of health care for everybody. So if we expect to have a health system that produces high-value health care at reasonable cost, we've got to start with changing the way Medicare operates. And as Brad said, the basic idea behind Ryan's general proposal is to give informed consumers a choice. They'll be able to select traditional Medicare if they want, but if there is a better alternative as far as they're concerned, they can select that, and that changes the nature of how the program operates. If you do it that way, then health plans and providers are no longer incented to just find more things to do so they can raise their payments. Instead, their objective changes to finding smarter ways to treat patients, and that potentially could save money and improve healthcare outcomes at the same time.
So, in essence, and again, this is not kind of pushing a line or being pejorative, trying to be, but that is essentially privatizing healthcare, isn't it? I mean, Medicare, is it not, Brad? Medicare
is already, in many ways, a private program.
How so?
The government contracts with insurance companies to manage its operations across the country. The main non-private part is the payment from taxpayers to healthcare providers. That's not private. That's direct transfer from the Treasury to them. And then the other non-private part, the other part that has government control, which would be retained under Ryan, is there is a raft of requirements that the Medicare Advantage plans, these are the private plans that now exist in Medicare, must adhere to. They must provide all of the Medicare benefits. They cannot deviate from that. And under the Ryan plan, those rules would be retained. So, in fact, it's a mixed system now, and under Ryan, it would remain a mixed system.
So, Bradley, before we go back to Brenda, I'll let you weigh in.
I have several points to
okay, I know you do, Brenda.
Yeah, sure.
Let me Bradley, and then you come right back.
Yeah, I mean, to this notion of the extent of private enterprise in the healthcare system. I mean, I totally agree with Joe. We definitely have a very mixed system now. I mean, if you think about all the providers, hospitals and physicians, I mean, they're all private drug companies as well. And about a quarter of seniors in the Medicare program are in these so-called Medicare Advantage plans, essentially where they opt out of the traditional fee-for-service program and opt into a private health insurance plan. But the big issue is right now 75% of Medicare beneficiaries are in the traditional plan, and the government is essentially acting as an insurance plan and setting the rules, setting the reimbursement rates. And I think on one hand, conservatives get very hung up on the fact that that's too much government influence and having the government set those rates rather than the market. Whereas progressives say, well, that's kind of the only way that we'll be able to control costs, having the government as this big player put its big heavy foot down and say, we're not going to pay $100 for a physician visit. We only want to pay $80.
Brenda, go ahead.
Yes, I agree with the last statement in that the government does cover the traditional plan for 75% of beneficiaries, and that's why Medicare is a major driver in controlling costs. And I disagree with a previous point that was made. There was a study that just came out in the New England Journal of Medicine, I think it was this week or last, that looked at Medicare and Medicaid costs per beneficiary and the private sector. And in recent years, it discovered that cost for private sector was more. And in the next 10 years, we're expecting private insurance to grow at about 5%, but Medicare at about 3.1%. So to me, this doesn't really fit with the claim that costs are out of control. We know that there is a solvency issue and something needs to be done, but we don't think it should be shifted for seniors to pay for it, because under the voucher plan with Ryan, you can make a choice, but if that voucher doesn't pay everything for your care, you're going to pay out of pocket. And contrary to the belief of many, a lot of seniors are not wealthy, and they can't afford to do this.
Go ahead, Brad.
Yeah, so maybe if I could, I've got several questions in my head for both Brenda and Joe. But I guess for Brenda, right? So if we think about like historical healthcare spending, on average being about like 6% per year. And as Joe said, the Medicare actuaries say every year that this system is unsustainable, right? We can't spend this amount of money under the current tax structure. I guess my question, Brenda, is like, well, what do you think ought to happen, right? So if you're kind of ruling out the notion of having Medicare beneficiaries contribute more because they can't, are you willing to ratchet down on hospitals and physicians and pharmaceuticals even more than the ACA did? Or are you thinking about raising taxes above where we are now? Because something's got to give. I mean, we kind of say, oh, we'll flip this magic switch and suddenly we'll become much, much more efficient in the healthcare sector. But we've been very, very inefficient for a long, long time, and it's kind of hard for me to imagine something changing anytime soon.
I do think we need to make some changes, but I don't think we need to dismantle the system that's been working pretty well for a long time. What I would say is that we need to take a look at what is put into the Affordable Care Act to help reforms. What was put into that plan were ways that would incentivize doctors to work based on quality and get paid on quality as opposed to lots of tests. We have already seen some success of this. Since the health care reform law was passed, the Medicare solvency has been extended for 8 years, and that's just in the last couple of years. People have gotten free preventative screenings, help with prescription drugs, and there's a number of ways that we think that the system can be strengthened as opposed to dismantling it to save some money. I mean, one is let the things that are in place in ACA go through, such as accountable care organizations. But there's other things, such as you could let the Secretary of Health and Human Services negotiate prescription drugs in Part D. That would save hundreds of billions in dollars. You could continue and reduce payments to MA plans, Medicare Advantage plans, to what it costs Medicare. So it's a level playing field, and if people want to choose those, fine. You could also extend rebates for drugs used by beneficiaries who are dual eligible, those who get Medicare and Medicaid. And you could also improve the system by adding things that people need, such as hearing aids, eyeglasses, and dental care. So those are just some of the ideas. And again, the main point is I don't think we need to dismantle the system.
So, and I'd like to hear, before Brad comes back and kind of probes a bit more, I don't want Bradley to probe as much as he wants in this conversation. This is great.
Sorry.
No. That was great, Brenda.
We're very passionate about this.
No, that's good. I'm great.
that was great.
No, I wasn't saying that's a criticism of your response at all. No. But I want to hear how Joe Antos would respond to what Brenda said.
Sorry, what's the question? I don't get it. What Brenda said is, let's have more benefits. I think that's a great idea as long as we have the resources. But we don't have the resources. We have an incredibly efficient Medicare program. The ACA did nothing to improve the efficiency of Medicare. And the reason is that if you don't change the way Medicare pays for services, which the ACA does not do, then you don't provide an incentive for providers and health plans to operate in a different manner. Well, unfortunately, we have many decades of experience trying to lower prices set by the government for various services in Medicare. And what we've found time after time after time is that when you pinpoint a service that you think is overpriced, which we did this in the 80s and the 90s all the time. I was in the Medicare program, and I was part of that. And what we found continually was that when you try to do what the ACA does, which is to lower prices paid to providers for various services, under the fee-for-service system, they actually have an incentive to provide more services, not fewer services, regardless of their actual value to the patient's health. And that's the problem. Everybody acknowledges that we have way too many tests, way too many x-rays, way too many office visits, way too little production out of the health sector for all that money. And the reason, principally in Medicare, is because it's a fee-for-service program with the false promise that the taxpayer can pay for everything no matter what happens. We've got to be smarter about this, and unfortunately, I don't see smarter coming out of the ACA.
So Bradley, go ahead. But I was going to have several questions here. I'm going to encourage our listeners, by the way. We are live here in this segment, 410-319-8888. Your thoughts on Medicare. Many of you are on Medicare. Many people are really concerned about this issue. Please bring your questions and your opinions to the airwaves at 410-319-8888. And you may get three very different answers here, but you can then weigh them, which is fine. 410-319-8888, Bradley.
Yeah, so just to push back a couple of things that both Joe and Brenda said. I mean, first with Joe, I agree with a lot of what he said, but I think you could probably admit that the ACA is trying to do a little bit with respect to payment reform, right? So he's right. I mean, the fee-for-service model is just full of inefficiencies, and all sorts of health policy analysts recognize that. The problem is we don't have a good alternative to suggest. And so the ACA is at least trying to do a couple things with so-called bundled payments, accountable care organizations. I mean, so really kind of wonky things that are trying to tweak the payments that have the hope of providing better incentives to providers to kind of scale back on inefficient treatments. Are these things proven? Definitely not. But I think there's a little bit of hope that these things might give promise to reforming the system a little bit. For something Brenda said, I mean, she's exactly right. The ACA did extend the Medicare Hospital Insurance Trust Fund by about 8 years. But that was primarily achieved through a combination of two things, right? Increasing taxes on high-income people and whacking the payments down for hospitals, right? And so lots of people think that that's totally appropriate. Yeah, let's tax the rich. Let's even tax the middle class. Well, the middle class is off limits, but
however you define what middle class means in America. But
but I mean, maybe you can keep doing that, but I mean, there's a limit to how much the rich can actually pay in taxes. And then if you're a Medicare beneficiary, paying hospitals and physicians less sounds great. But if you're a healthcare provider, and so much of your revenue is coming from the Medicare program, I think you've got a lot to be concerned about.
Well, let me. You raised something earlier, and there's like 4 or 5 arguments, some people call myths, some people call reality about Medicare that I want to walk through in the course of the rest of the show. But I mean, you said something much earlier, Bradley, and you responded, Brenda. And I just want to push this a little bit further. I mean, when you talk about costs, and we're going to come to the whole question in a minute whether or not the costs are out of control or not, and there's a lot of argument around that, and I want to get to that point. But assuming, let's say that some medical costs are outrageous, we spend twice as much as any other country in the world in healthcare costs, and in some ways, in many studies, saying we don't get our healthcare is not as good as some places that spend less money in some of the European systems that people compare America to. We can come to that as well, but it seems to me that one of the issues that politicians will loath want to address are containing costs that come out of insurance industry, pharmaceutical industry, the medical supply industry, highly paid medical specialists, the battles between hospitals, like where we are broadcasting from Baltimore, the battles between all the private healthcare systems and Johns Hopkins and the University of Maryland, and they're all battling over who's going to fly helicopters in, who's going to have the most machines, and then we got to put yourself through those machines, because if you don't go to MRI, you'll never find out what's wrong with you, so everybody's being charged. So, I mean, that's one of the things, Bradley, I think that people don't want to address. And it's probably the toughest nut to crack. It may be easy to make arguments in Congress to slash benefits, do more privatization, or do the opposite, but not as easy to make the argument about where the costs really are and how to get to them.
So I mean, bravo. I mean, excellent summary of a lot of the problems we face in the healthcare system. I mean, you're exactly right. I mean, a lot of the things you hit upon are essentially related to medical technology. So, I mean, if you really think about why healthcare costs grow at 6% on average or so every year, it's largely because we're inventing really new, cool machines, new drugs that just cost a whole lot more. And under our current set of incentives, whether it's the public program Medicare or the private health insurance system, largely through employment-based health insurance, private insurance, there's really no incentive in place now for anybody to kind of scale back and push back on that and say, wait a second, like that's probably not a wise allocation of our scarce resources. Let's try and think about getting a different health insurance plan that maybe doesn't provide this really gee whiz technological service that we probably don't really need. And so I think where conservatives and progressives differ is that progressives say, well, let's get our bureaucrats here in Baltimore working over at CMS to decide what we think the appropriate amount of services are. And you get conservatives like Joe and other folks in the DC think tank circle that say, well, no, it's really got to be a market-based system that has entrepreneurs coming up with better insurance design, better healthcare products, and that'll slow the growth in healthcare spending. And so you just get everybody, screaming at each other.
So, I mean, it seems when we asked that question earlier, before we go to break here, Brenda, you were kind of loath to want to kind of move to transform that system. Mm-hmm. Then some people would argue it needs radical transformation.
I would not say radical transformation. It's one of the most successful programs we've had in this country, and it's helped take a lot of people out of poverty. I don't know if we have time before the break, but I had a couple of points.
Well, why don't we do this?
Good.
Let's take this quick break, and then come back and you can hit your points.
Okay.
And we'll let Joe have at it as well. 410-319, because I know you won't forget your points.
That's true.
But 410-319-8888. We're looking at Medicare, which is one of the battlegrounds in this presidential election, and also has a lot to do with the future of where American healthcare are going. So stay with us. We'll be right back. Welcome back. I'm Mark Steiner. On our way to this conversation, back to our conversation about Medicare, a little community note here that I have to remind you, those of you listening, our listeners from all over the state and states, that if you're a nonprofit organization and would like to find out how to get your message out to our listeners, you can join us at WEAA's Community Ascertainment Breakfast, Thursday, August 23rd, 7:30 to 9:30 a.m., the James E. Lewis Museum of Art in downtown Baltimore. This is your chance to meet our hosts, producers, learn about our community cares program, how to get PSAs on the air, media partnerships, and much more. Doesn't cost a dime, but space is very limited, so we advise you to call Sandy Mallory at 443-885-4531. That's 443-885-4531. And we are talking about Medicare. We're going to come to Willie and Russ and the other callers after Brenda has her say, and Joe and Bradley come back on this issue as well. Bradley Herring is Associate Professor of Health Policy and Management and Director of the PhD Program in Health Economics and Policy at the Johns Hopkins Bloomberg School of Public Health. Joe Antos is the Wilson H. Taylor Scholar in Healthcare and Retirement Policy for the American Enterprise Institute. Brenda Sulick is Senior Policy Analyst with the National Committee to Preserve Social Security and Medicare, 410-319-8888. And you were about to list some points, Brenda. Go ahead.
Yes, a couple of things. Talking about why healthcare is so expensive. One study put out by the Commonwealth Fund talked about that it's a common assumption that they think Americans get more health services than people in other countries. But in fact, they found out that we don't go to the doctor or the hospital as often as people in other countries do. Some of the reasons for the high prices are, as mentioned, medication, medical services, expansive technology, and chronic health problems that a lot of Americans have. Obesity is a major problem in our country, and diabetes as well. But the point I was going to make earlier is going back to the Affordable Care Act. Obviously, I think this is a good thing for seniors, but there are some safeguards in there to help control costs. One is the Independent Payment Advisory Board, called the IPAB. This doesn't do any rationing. It does not affect the beneficiaries, but it's a group that would help look at the growth of Medicare costs, and if they were going above a certain point, they would put in measures to control those costs. The other thing that raises a lot of costs is administrative costs. Some of you may be familiar with the 80-20 rule that came out of the Affordable Care Act. Some of you may be getting rebate checks right now from your insurance companies. What this said is under ACA, health insurance companies have to spend at least 80% of consumers' premiums on patient care. And from now on, if they don't do that, they have to give a rebate directly to the consumer. And there's 12.8 million Americans who are going to be receiving $1.1 billion in health insurance in August. So I think that's another, and it also shows. I don't think there are some many good private health insurance plans, but a number of them can save money a little more and focus more on care as opposed to marketing and salaries.
So, and Bradley, you were saying something during a break, which I found counterintuitive but interesting.
Yeah, so we started talking about further conversation about all these technologies, and I kind of put perhaps the very unpopular position out there that perhaps we shouldn't be so singularly focused on reducing healthcare costs, right? So certainly healthcare costs have risen a ton, but when most analysts look at that, it's largely due to new technologies. And then when you try and start doing some of these cost benefit calculations about the advent of these new technologies, sure, we're spending a whole lot more money on healthcare, but at the same time, we're presumably valuing the extra life expectancy we're receiving through some of these treatments. And on net, it might actually be worth it. David Cutler is one of President Obama's biggest healthcare advisors, economist from Harvard. He and Mark McClellan came out with this pretty oft-cited paper that kind of came to the conclusion, focusing on technologies to address low birth weight babies and technologies to go towards the treatment of heart attacks, and kind of made these calculations that, we're spending a whole lot more on these things over the past 10, 20 years. But would you really prefer to live in a world where we didn't have like these great advances like stents and catheters to make us better off? And so I think the big challenge is that over time, a lot of these new technologies are indeed beneficial, but at any point in time, lots of people are receiving them inappropriately. And so yeah, we'd probably never wish that we hadn't invented stents to treat heart attacks. But then a lot of people are probably receiving inappropriate treatments.
So on the way to the phones, Joe, I'd like you to be able to kind of have a retort or comment on what you just heard our other two guests talk about.
Yeah, sure. I think Brad is making a very important point. That's I think one of the biggest problems we have. But you have to ask, why is it that we've had such an explosion of technological innovation in the past? It's really been since probably the early 80s. I think before that we didn't see that much. Partly it's because of just the advance of basic science, but a large part of it is, in fact, the Medicare program and the uncapped entitlement that said we're going to pay. So once you put the money out on the stump, especially if you put lots of it out there, then you get all kinds of people saying, "I've got an idea that potentially can marginally improve patient health, maybe, and I can get rich doing it." So in a sense, the Medicare program, I would argue, and there's a study by a Harvard economist whose names I can't remember. Brad, you know who she is. Who basically the implication is that the Medicare program really triggered this explosion of medical innovation because of the money.
Right. Amy Finkelstein from MIT. Yep.
Right, exactly. And so and that's great. But then we have to ask ourselves, where is the money coming from, and what are our alternatives in this country? How much of our resources do we want to devote to health care for seniors and for everybody else? How much do you want to put into education, into transportation, into energy, into defense, you name it? We are not having that discussion, unfortunately, and we need to have it.
Well, I think that we've had that discussion a lot on the air here. I think it's an important discussion for America to have, which is the kind of America that we want, and are we willing to pay for the America we want? And that is always that is the question. And how do you pay for it? It's another question. Eisenhower might say you tax the wealthy at 70%, but Eisenhower's not here now. So, but I think that is part of the issue. Let me go to the phones here. Some folks have called in and have dropped waiting. So Willie and the other callers who left us, we'll take you right away, 410-319-8888. But Russ on the east side, you're on the air. Hi, Russ, you're on the air. Welcome.
You and your guest.
Welcome.
I think it's kind of a futile exercise, should I say, to just look at Medicare, because insurance and the use of insurance is going to fuel the cost and the increase of anything just about. I think if we're going to be successful, what we need to do is look at the cost of insurance, the cost of medical delivery system in our country, from the cost of a medical education and what doctors have to pay now to go to university, right on through to end-of-life care, where, we spend a terrific amount of money on end-of-life care for people who are going to leave us anyway, because that's just the way life works. There are people who need to be in palliative care and perhaps assisted living, or they're at the end of life, or in what we call hospice. And we're kind of reluctant to do that. And I know I love my mother, and she's 85, but I know that the day is going to come that she's going to move on. I just want her to be comfortable in that situation when there's nothing else can be done to save her life. So I think we need to look at the whole thing and then figure out how we can reduce the cost. And the last thing I want to say, Mark, is we need to look, too, at the redundancy in the medical delivery system. Does every doctor need his own x-ray machine? Does every doctor need their own diagnosis machine for prostate cancer, the cost of $40,000 to $60,000 per diagnosis? Because those machines cost a couple of million, from what I understand. So I just like to see us get our minds around taking a look at the whole program.
Well, let me take the last thing you said, and then we're going to go to Vince, our next caller up, before we kind of walk through the myth and reality of some of the things between Ryan and Obama and Republicans and Democrats as they battle for Medicare. We were also talking during break, Bradley, but I made the comment to you that in other countries where there are more national healthcare systems, people do control cost, but that means they control the marketplace because they can say, no, you're only going to have these 2 MRI machines in Naples. You're not going to have 7. And so I mean that does exist. And I found it interesting when Romney was in Israel, he was lauding their healthcare system, which is a gigantic government single payer system.
right.
Which really I found interesting. Oops. But what about that? I mean,
that's exactly right. I mean, I mean, Russ hit it on the head. I mean, you have lots of these technologies that, on balance, it's great that we have MRI machines, right? But the problem is we probably have too many. And then once if you think about like a hypothetical example of like maybe a city really could get by with just 2. It's kind of hard to say to anybody, well, no, you can't get that third one. And then the problem is once there's a third facility that has it, well, what do they want to do? They want to keep patients cycling through so that they can get paid. And when there's really no insurer incentive to kind of scale back and say, well, no, we're not going to cover that MRI. And Medicare is loath to do this because then you get all sorts of cries about rationing or worse yet, death panels. With insurance, I mean, people are just going to, keep on racking up the bills.
Well, I'm going to come to this death panel question because it keeps hopping its head up. There is a real commission that's going to be looking at future costs, which people who oppose President Barack Obama are calling death panels. But the question is, even for people who support President Barack Obama, these panels really going to answer the question that have to be answered. And they're really not death panels, but they are kind of looking at the cost of Medicare. But I'm not sure they have the teeth to deal with it. So,
sorry.
Go ahead, Brenda, and then we'll go back
I
to the
just
phones.
wanted to make clear, in case anyone's out there, because this has scared a lot of people, there's no such thing as death panels.
Right.
There was never anything as death panels. And what I was mentioning before is this was put into the Affordable Care Act, is this IPAB, the Independent Payment Advisory Board, and I believe that's what you're
right. That's what I'm referring to. Exactly.
Yes. And there's been some misinformation about that. It is not a rationing board. It will, again, look at costs and make proposals to lower costs, and then Congress can vote on this. But, again, as far as how much teeth that has, that's to be seen. Congress these days haven't been able to agree on a whole lot.
Very quickly, Bags, I want to get these callers in who.
Yeah, sure. I mean, so it's fascinating just the politics of Palin for saying death panels, and it kind of related to originally Medicare was, and to kind of piggyback on something Russ said earlier, we don't really have good conversations about palliative care or even advanced directives, and so the provision in the Medicare proposal was to try and reimburse a physician if a patient actually wanted to have a conversation about that, and so it got twisted, and now the death panel term incorrectly applied to this IPAB entity.
And I think advanced directives is an issue unto itself that we've talked about in this show before because people need to do that in their own lives to save a lot of grief. But before we go back to Joe Antos, let me, as I promised, go to our callers who have been waiting. Willie, you're on the air. Willie, you're on the air. Turn down your radio so we can hear you, please.
Okay.
Hi. You're on the air.
Oh, okay. How y'all doing?
Very well.
Good.
That's good. My question is, I've been paying into Medicare for quite a few years, and I'm almost 65 years old, but I won't be using Medicare because I'm a veteran. I go to VA hospital. What happened to all the money that I paid into Medicare? I mean, what happens with that money?
The government's going to use it to cover the health care expenses of your fellow senior citizens. I mean, sorry to seem glib about that, but I guess the short answer is that.
Actually, Brad. Actually, I think more
Joe
correctly, the government already spent the money. It's gone.
That's right. Yeah. So actually, I mean, I wanted to follow up on something Brenda said earlier. I mean, she talked about how Medicare is a successful program, very popular, and I mean that's true. I mean, polling very, very popular among seniors. They love it, and in some sense, Willie's case notwithstanding, but for the most part, Urban Institute researcher, I think Gene Sterling is his name, ran some numbers and said for a typical Medicare beneficiary turning 65 and starting to receive benefits, that couple, I think think if I get the numbers right, probably paid about $10,000 worth of taxes into the system, inflation adjusted, over their working lifetime, and are expected to receive about $50,000 in healthcare benefits for the rest of their lives, right? And so you can view that at least one of two ways. One is we've promised them way too much, or second, we didn't tax them enough. But in some sense, like, the younger ones among us, we're the ones kind of left footing the bill for all these promises you all older folks have made to yourselves.
I think he was looking at me when he said that.
Can I respond to that?
Go ahead, Brenda.
I actually have that study right in front of me.
Yep.
And the study by the urban researchers said that there's been some different readings on it, that people that pay into Medicare are getting 3 times more out of it than what they put into. But there's been a lot of question about some of the assumptions and the return rates they've used. And just the point I want to bring up is people have paid into the system, and you don't know if you're going to be one of the people who needs health care. Maybe somebody doesn't need as much, but that's why it's a big risk pool. That's why it's a safety net for people, because you may need it. And there's a small percentage of Medicare beneficiaries who take up most of the cost because they're very sick.
Yeah. I mean, no doubt. I mean, medical expenses are highly skewed, and there is this, inherent underlying appeal of having a pool where the healthy people subsidize the sick. But still, you can think about a system being in an actuarial balance where the money they pay in is essentially equivalent on average to the money they're expected to receive coming out of it. And
So how would you know what you're going to get coming out of it?
A cohort of people, right? So imagine like all, the entire cohort of people who are turning 65 this year. Yes, there's going to be lots of pooling from the sick people to the healthy people, from the healthy people to the sick people among that cohort. But, in some sense, from an actuarial basis, you would kind of liked that cohort to have paid for themselves collectively and pooled amongst
but
each
don't
other.
But in some ways, it's not just a pragmatic question. It becomes a philosophical question and a philosophical political question about what kind of America and society do you want. I mean, do we pay into many things? I mean, if I am 65 or 70 years old and I'm paying taxes, I'm paying for schools. I have no children, but you still pay taxes for schools, right?
Oh, sure. Well, I mean, I'm fine with that, right? I guess as the father of a 3 or 4-year-old and a 7-year-old,
I'll pay for your kids' school.
But yeah, I mean, so I think that's right. I mean, I think to focus on a particular tax and a particular benefit in isolation can probably be a little misleading.
So I want to go to Vince, our next caller. But Joe, I haven't heard from you on this particular issue. Why don't you weigh in, then we'll go to Vince, our next caller up.
Well, I'm not sure that there's much to add here. We have made a decision, which is a good decision, that we're going to tax ourselves to meet a whole host of social objectives. That's a good thing. I think that isn't the debate. I think the debate is now, especially in a tough economy that isn't getting any better, how much more do we think we can put into the system, and especially with regard to Medicare, how much more do we want to put into a system that is so blatantly inefficient and wasteful and productive of so little for so much money?
So, well, I'm going to come back to that last sentence you just said. Whether or not Medicare is blatantly, what was the word you just used? Wasteful?
Inefficient and wasteful.
So,
You can't find any serious analyst who doesn't agree with that. You can find plenty of people who disagree about what the solution is, but David Cutler, among others, has signed on to the idea, which is very common in health policy, that Medicare probably spends 30% more than it should if you had a really efficient system.
I would agree with that, and that's why the Affordable Care Act looked at changing the healthcare delivery system. And as I said earlier, the study that just came out of the New England Journal of Medicine shows that Medicare spending grew less rapidly than private insurance. So to me, that sounds more efficient in some ways.
let us go to the phones here again and get another caller in at 410-319-8888. And that was one of the myths I was going to wrestle with, or the questions whether it is a myth or not I was going to wrestle with that we just talked about. And Vince, you're on the air.
Hi, Mark. Thanks. Well, the discussion of the last 5 to 10 minutes has sort of stolen my thunder a little bit. But
Sorry about that.
No, that's okay. But I think the points that are being raised about, I think that Brenda initially raised it about that we as a society and as a culture need to have the conversation about how much are we going to do for our elderly folks. And I'm actually a hospice nurse, and so I see every day sort of what we can do with palliative care, and but I think the larger question that we need to have is, are we going to put grandma, who's 95 years old, in the ICU? I mean, not to put it crassly like that. I mean, you understand what I'm saying, though. It's, how much are we going to do for people as they get older? And then the other point that I just wanted to make was, I think that the issue with Medicare is tied, as I think one of the other callers said, to the whole healthcare system. And I have just 2 words in response to that. Single payer. We need a single payer system. The costs are not going to go down in any significant way unless we have that. President Obama, when he was initially thinking about his healthcare overhaul, what is the first thing that he did? He brought in the representatives of Big Pharma, of the medical device manufacturers, the Association of Health Insurance Plans. He wanted to preserve the private, for-profit health insurance and healthcare system industry. And it looks at healthcare as a commodity. So, that's why whenever I hear these discussions, I feel like my blood pressure is going up.
Don't do that. But I understand.
Because really the only answer is a single payer system. You could tweak a little bit here, and I understand what he's doing a little bit in the ACA, having these accountable care organizations. He's tweaking a little bit here, but the change that we really need is a single payer system.
Well, Vince, I'm glad you raised the issue, and it comes up on the show all the time. We usually have this. We didn't do it this hour, but we often have a single payer advocate in these discussions because it adds more to these discussions I think you need to have. But let our guests kind of end up in these last 4 minutes and wax forth a bit about that. How would you respond to him, Bradley?
Yeah, so I guess I'll state off the bat. I'm personally not a single payer advocate. I'm certainly an advocate for universal coverage, or at least universal access to coverage. Me personally, I'm optimistic that a system in which you have private health insurers competing with one another under the right set of incentives. I don't really think we've had that in our history, having an efficient set of incentives in the private health insurance system could achieve that. And right now, I think if we look internationally, maybe a country like Switzerland or the Netherlands could kind of be close to that notion of using really large nonprofit health insurers. Coupled with subsidies that actually work in a direction in which low-income people get more assistance and higher-income people get less assistance. And the way we subsidize private health insurance coverage right now is actually the opposite way, unfortunately, through the subsidization of employment-based health insurance.
So, and Brenda, how would you respond to Vince?
My personal view, aside from my organization, I think I am an advocate for single payer. I think it's in the current political environment, it's just not going to happen. When healthcare was being discussed a couple years ago as they were putting the proposals together, we heard about this a lot. But I just don't see in our current environment how it's going to happen. And I think what the president tried to do is have the combination of the private-public system, and that's where we are right now. Maybe in the future, but I personally don't see it happening anytime soon.
And my guest, Joe Antos, you're not actually for a single-payer system.
Oh, I'm very enthusiastic about it. Look, the problem with single payer is the problem with all of these ideas about sort of top-down controls. How do you know when you've pressed far enough? This is a democracy. It's a political system. Single payer is doomed to failure in this country because we in fact have legislators who are highly responsive, probably a little too responsive, to various advocates for the elderly, advocates, of course, for the health industry. And so, single payer might look good initially, but once it's in place, all the political machinations go right back into action, and then we have the problem of exactly where do you cut, who do you hurt. It's the same problems that we've had all along. It doesn't fundamentally solve the problem. So, we've got to decentralize, and we've got to let patients and doctors and health plans in on the action, or we're sunk.
Well, lady and gentlemen, I want to say thank you all three for being here. There's been a really good ranging discussion. I appreciate you taking the time with our listeners here across the country. And Brenda Sulick is Senior Policy Analyst at the National Committee to Preserve Social Security and Medicare. Pleasure to have you with us, Brenda. Please don't be a stranger and come back.
Thank you very much. It's a pleasure.
Joe Antos, William H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. You as well. It's good to have you with us, and we'll look forward to talking to you again.
Thank you very much.
And Bradley Herring, who is with us once again, Associate Professor of Health Policy and Management and Director of the PhD Program in Health Economics and Policy at the Johns Hopkins Bloomberg School of Public Health. Always a pleasure to see you and have you in the studio.
Yeah, thanks for having me back.
And thank you all for calling in, and really interesting thoughts will be raised here during the course of this hour. We'll clearly come back to it, one of the big issues facing America.